Welcome back to Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I'm an interventional cardiologist with over 10 years of experience. And the initiative of this podcast is to bring you evidence-based information on health and health-related topics. I have a fantastic, very special guest with me today, Dr. Sivarajan. Dr. Sivarajan and I were classmates back in medical school, and he is the full-time stroke specialist and heads the stroke unit at Kaveri Hospital in Chennai, Tamil Nadu, India. Today, we want to deep dive into everything stroke related. We know there's always a lot of talk and buzz about heart disease, but equally aggressive and equally common and equally debilitating is strokes. And Dr. Sivarajan is here to educate us all about it. Welcome to the show, Dr. Sivarajan.
Thanks, Dr. Maran. And as you said, we go a long way from medical school. And it's always great pleasure to see you whenever you come back to Chennai and interact with you. I admire the work you're doing with educating the masses about each and every simple things from lifestyle, diet, exercise, a lot of things that we doctors often don't know much about. And it's a great initiative that you're doing.
Thank you. I truly appreciate it. Honestly, in this process, I have learned a lot. And honestly, it keeps me accountable too. Like, I feel like I have to do more and I have to be more and focus on my own health. So it's been an interesting journey. Thank you so much for joining me. Sivarajan, though we did medical school together, our paths diverged after medical school. I went to the US and you went to the UK. Can you tell me a little bit about your education in the United Kingdom?
So it was a truly transformative one. And training in the UK opened up a lot of eyes and minds, and the way you see people and you interact. The thing that I loved training in UK is about communication. So you listen to people and somehow learn to empathize with your patients. And also the knowledge that we gained is enormous. And more than knowledge, the wisdom that comes along with it. So not only gaining the skills and knowledge, when to use it, how to use it, when not to use it. These are things that I cherish the most, learning from the United Kingdom and the NHS in particular. But after medical school, I went to UK in 2002, then did all my basic medical training, mostly in East Anglia and London. And then I did my higher specialist training in Oxford University Hospitals, where I did my geriatric medicine, general internal medicine, and also stroke medicine. After I finished my clinical training, I did research training in stroke, acute stroke imaging, where we did a lot of research on acute MRI changes, looking at metabolic changes, connectivity changes using diffusion tensor imaging, and so on. While I was there, I always had a passion to come back to India, help our population, especially in stroke, because as we all know, right from medical school, stroke is one of the least treatable problems. We didn't have much to offer, but while I was there, I could see the transformation in stroke care. So that drove me to come back here and set it up here.
Oh, that's really very, very nice. Sivarajan back in medical school was one of the quietest human beings, very soft-spoken. And now I've truly seen a transformation, especially in your communication. Sivarajan takes care of a lot of my family too. So I see him interact as a physician as well. And you're right, when we go from, our medical school training and kind of get out of a comfort zone, we learn so much, and it's so great that you have been successful in bringing it back to your home country. And, I applaud you for that, seriously. So our topic today is stroke, right? Can you, everyone knows a lot about heart disease. I feel like the heart awareness is a lot because of maybe the sudden cardiac death, etc. But when we talk about stroke, when I consent a patient for a heart procedure, I always tell them there's a risk of stroke. No one wants to live with stroke, but I don't think people also know what happens in a stroke, how does it come upon, etc. So why don't we start with the basic definition of what is a stroke?
A stroke is an acute neurological emergency that is often due to a blockage of blood flow to certain parts in the brain. Sometimes it can be a bleed into the brain. So 80% strokes are due to blockages or ischemic in nature, and 20% can be due to bleed. Out of the two, hemorrhagic strokes or bleed-related strokes are most devastating, especially the subarachnoid hemorrhage. often we see 50% of patients don't survive with often a day. The treatment options are quite extreme in hemorrhagic stroke. Often they have to have decompressive surgery and so on, and mortality is a bit high. But luckily, in ischemic side, with newer developments, we have quite a lot of advancements. So what happens in stroke when it strikes is often there is a loss of function in certain parts of our body, depending on where the stroke strikes. It can be loss of awareness, loss of speech, dizziness, visual disturbance, loss of motor function, and so on. When a heart attack happens, there's a lot of pain, breathing difficulty, people call for help immediately. But we still see patients don't take stroke seriously. Often they feel like they've slept awkwardly, and that's why the arm is numb. They are feeling dizzy because of vertigo and so on, and they present to us very late. And that's putting brakes in the first line treatment, the golden hour treatment that we can offer them.
Yes. So, you absolutely hit the nail, right? Chest, when you're having a heart attack, there's chest pain. It's like a dramatic event. You sweat and you can't breathe, and then there's this impending sense of doom. There's like a little drama going on, right? But the stroke is like more quiet and etc. and can be brushed off aside. And we all get numbness. I mean, every time I get numbness in my arm, I'm not going to think it's a stroke. So how do I even, tell myself something is really wrong versus, oh, I can wait and watch? Like, how do I make the difference?
So the real thing is to see the character of the change. If it is out of character, then we have to take it seriously.
Okay.
And easiest way to identify is, we call this a BFAST, the stroke mnemonic, to identify just for general public. Like B for balance, if there is a loss of balance which is out of character, if there is a change in visual parameters like blurred vision or a particular half of vision getting disturbed, and if there is a facial asymmetry, so if somebody is noticing someone, or if you can see yourself in the mirror and notice that one half of face is a little asymmetrical, if you ask them to put their arms up and if one side drifts down, and while they are asked to speak, they may not be able to produce correct words, or if they may make correct words, but it may be slurred. And if they have any of these signs, then it's time to call for help. Okay. And we often insist to come in an ambulance, because they can check your parameters and make sure they take you to the right place, because they have to go to the stroke ready centers, not to any smaller hospital or setup where they cannot manage them.
We know heart disease is common. How common is stroke?
It's extremely common. Apparently, it's going to be the third highest mortality causing disease after heart disease and cancer. And at any given time point, at least 1 in 6 individual on earth is likely to have a stroke above 25 years of age. And
25 years of age, that's a scary number.
Yes. And over the years, we have seen the incidence of stroke slowly dipping down from old age to middle age. That's even more scary. Like same thing with MI.
Yes, absolutely.
And at any given time point, roughly the greater Chennai population is roughly 12 million. And around the world, 12 million people suffer a stroke in each year. That's almost 10 crore, 20 lakh population are having a stroke at any given year. And if you compare the population of Tamil Nadu as a whole, we are 6% of Indian population, and which is same as UK population. According to UK statistics, almost one stroke happen every 5 minutes, which translates to roughly 280 plus strokes per day, almost 1 lakh stroke per year. So if you can imagine, UK has a very advanced healthcare system. If they are going to have 1 lakh strokes a year, and you can imagine how much it's going to be in our
So the short answer to my question, it's extremely common. It is something we have to be aware of and look for and take care of it. That's what I feel like I'm getting out of this. For everyone knows heart disease. If you smoke, you have high blood pressure, high blood sugars, blah, blah, blah. If you don't exercise, if you don't eat well. But how about stroke? What are the risk factors for stroke itself?
Surprisingly, the stroke risk factors are same like cardiac risk factors, and fortunately a lot of them can be easily prevented, but unfortunately we don't do it properly. So of 90% of strokes, almost the top 10 are modifiable. Simple like hypertension, diabetes,
high blood pressure,
dyslipidemia, high cholesterol, smoking, excess alcohol or substance use, and metabolic syndrome, people with heart ailments leading to atrial fibrillation. And often youngsters, when they have a stroke, we look for patent foramen ovale. And sometimes people who often have paroxysmal AF may not be picked up on a
Yes,
routine Holter
yes.
test.
We do
Probably
that
well know
all the
that
time.
NT-proBNP levels often go up before they develop paroxysmal
Yes.
AF, and that can also be a good screening tool. Carotid artery disease, very common in smokers and uncontrolled diabetes individuals. And screening for carotid artery is not routinely done in our
Yes.
master health checkups, and we've been trying to implement that in our hospital,
Yeah.
where we can pick up carotid artery disease after 65 plus and so on. So a lot of things can be easily modified, but
It's not
unfortunately,
done. You said a few terms. I think I want to kind of deep dive or explain it to the general audience. You talked about PFO or patent foramen valley. Basically, it's a small hole in the heart, which is 20% of the population. It is open. It's a normal communication, and it is open, and there's no problem with that. But when you have an opening which communicates from the right and the left side of the heart, and you have a clot in your leg, that clot can travel, get across that little hole, and go to the brain and cause a stroke. So that is number one I wanted to explain. And I think the next thing you talked about is atrial fibrillation. The heart in general has 4 chambers. The top 2 chambers are called the atrium. Instead of the top chamber and the bottom chamber having a synchronized dance, the top chamber starts beating very fast, very irregularly. Fibrillation, that's what it's doing. And when it is doing that, the blood does not go from the upper to the lower chambers. Instead, it sloshes back and forth, and it stays stagnant. And blood is not designed to be stagnant. And if the blood is stagnant, it forms clots. And when the heart goes from fibrillation to actual beats, that clot can break loose and go to the brain and can cause stroke. And the final thing is the carotid, which is the big blood vessel going in our neck to the brain. So are you telling me like how they screen for coronary artery disease with a cardiac CT scan or something, routine screening of the
it's a
carotid
simple
artery is not
Doppler
done?
scan.
It's not done.
Easy to do, 10 minutes.
Yes.
That's all it takes.
Yes.
And apart from this, diet,
Yes.
sedentary lifestyle, and obviously sleep apnea.
Oh, that's a hot topic. How does sleep apnea lead to stroke?
Very underrated. Sleep apnea is a huge issue in our population, and with increasing obesity in youngsters, we do get a lot of side effects from sleep apnea. There's an increased incidence of type 2 diabetes, hypertension, and it can also alter the way the heart pumps and increase the risk of paroxysmal AF. And it also releases stress hormones that can put stress on the arterioles, premature atherosclerosis, and so on. And we do see a lot of youngsters who have sleep apnea coming with very large strokes. After screening everything that we can screen, traditionally almost 20% of our stroke patients may not have an identifiable cause. And in those individuals, often a sleep study has picked up that could be one of the potential causes for stroke.
Certain things are very distressing almost when it comes to stroke, right? There is some sort of a preventive mechanisms for coronary artery disease. People go get blood work and blood check. This seems like such a big problem. You only have one brain, and the screening is not happening as much as we would like it to be. That's really distressing. Your thoughts on that?
If you look at China, for example, until recently, they had a very high incidence of hemorrhagic strokes.
Okay, there is bleeding in the brain.
Bleeding in the brain. Most of the general public were not treated or picked up with hypertension. As a country, it has become more economically advanced and healthcare has improved. They are seeing a very huge drop in hemorrhagic rates or bleeding rates, and they are almost similar to other Western world where there is an increased incidence of ischemic strokes.
Okay.
So most of the risk factors, as we discussed, are due to lifestyle conditions like type 2 diabetes, hypertension, and dyslipidemia, and so on. All of them can be easily screened. Often smokers can develop polycythemia, secondary polycythemia.
Where the blood, too many red blood cells and blood becoming too thick.
Too thick and increased traffic in the blood vessels. I see a lot of youngsters coming with strokes just because of polycythemia. They have no other risk factor.
Because of smoking.
Because of smoking and dehydration.
Okay.
And I've met a very young college girl the only risk factor she had was she was only living on chicken in a hostel. So extremely poor
For
diet,
nutrition.
nutrition.
Yes.
I do see a lot of youngsters, especially who are pure vegan, very high homocysteine levels.
Okay. Okay.
They have extremely low B12, folic acid, B1 levels. These are all sort of out of the
The zebras in the stroke
strokes.
regimen.
But the majority are due to, so it can be easily checked with HbA1c, lipid profile,
Yes.
CBC, and so on. And if they fall in a certain bracket, then we can do a carotid Doppler if they're above 65, especially if they've been smoking in their past, if they have uncontrolled diabetes.
Then you do screening. You kind of touched on veganism, so I feel like it's our duty to explain that. What happens in veganism to the vitamin B12 deficiency and folate deficiency, which leads to homocysteine? Can you kind of deep dive into that a little bit?
So the vegan diet has very poor B12 folate.
Because those are animal sources,
yes,
and in the veganism it's not available. Okay.
And even if you can fortify food with B12, like most of the cereal in the West is fortified with B12, often it's poorly absorbed. A lot of us have intrinsic factor deficiencies, and as we age, pernicious anemia is high in incidence because of acidity and so on. So the risk of high B12 deficiency and folic acid deficiency is exponentially seen more in the vegan diet. Which is a important precursor for the production of homocysteine and degradation of production of homocysteine. So when the homocysteine level rises, it causes a prothrombogenic tendency.
Prothrombogenic means it makes the blood maybe a tendency to form clots in the blood. Yes.
And they can be on the venous side or more on the arterial side. When it happens on the arterial side, it can cause heart attacks as well as strokes. And in Chennai, at least, I've seen a lot of IT professionals. The only risk factor we could identify was just pure homocysteine.
Oh, wow.
And the normal range is less than 15, but I've seen up to 200, 100.
Whoa, dude,
and so on.
that's a really high number. You definitely caught me by surprise there. So, for the heart attack, right? Like, when there are hospitals designated as hospitals which are capable of taking care of acute heart attack, or there are programs to transport the patient, like give them clot busting medications, then transport them to a hospital where cardiac cath can be done and stents can be placed. What are the parameters for stroke, like the golden hour? You mentioned that briefly. Let's talk on that.
So until early 1990s, stroke was pretty much a neglected problem. So the first randomized controlled trials on stroke unit care transformed the way stroke patients were looked at. So it showed that almost 50% mortality reduction if somebody is looked after in a stroke unit, like cardiac patients are looked after in a cardiac care unit.
Yes.
And until the 1995s, when we had the first stroke thrombolysis trials, there was nothing much to offer for stroke patients. So the thrombolysis, the initial trial recommended the clot buster up to 3 hours of onset of stroke. And that truly transformed the stroke care. It took almost another 20 years for another breakthrough when we had the mechanical thrombectomy, meaning the clots could be removed from the arteries if they are not easily dissolvable by the clot busters. So if the clots are in the inner vessels, like in the middle cerebral arteries or the branches, it's almost 90% rate of dissolution. If it is in the terminal ICA, it is about 50%. If it is in the carotid, only 20% of clots could be dissolved. So in this scenario, we need another technique or a treatment to get the clot out to restore blood flow. Initial trials with the mechanical thrombectomy were a huge failure, but luckily from 2015 onwards, the device has become well refined, and the research industry has put in a lot of effort and money, and the devices that we have now are extremely easy to use, and they have very good success rates and recanalization. But off late, with advanced imaging, often we see stroke cannot be, the brain cannot be salvageable up to 8 hours and so on. But with advanced multimodal imaging, we do see penumbra, areas of brain that are still salvageable.
What do you mean penumbra? Talk about that.
So penumbra so when a stroke happens, the area that is most severely affected is called the core, which is irreparably damaged or necrotic. The area that is around the core is still having a little bit of perfusion from collaterals.
So that can be salvaged and
Yes.
or improved upon.
So
Okay.
that's the main idea of both IV thrombolysis and mechanical thrombectomy.
So what is gone, but there are still areas which we can salvage. So therefore, let's go and try and save that. Okay.
And time is very important in stroke. Each passing minute, you get millions of neurons that can be.
So time is brain cells.
Yes. So the earlier you give the thrombolysis, like even though the golden hour has been extended up to 4.5 hours, if somebody can get the treatment in the first hour, the outcomes are much better.
Okay.
If you can give the mechanical thrombectomy within the first 3 hours, the outcomes are much, much better.
So good. So even if you have a stroke, you can still salvage that. And so talk about, apart from clot busters and, removing the thrombus itself, what happens after a stroke? How much function does come back?
So if we can initiate the treatment pretty much early, we do see patients, if with IV thrombolysis, there is almost a 60% return to productive life, functional quality of life. With mechanical thrombectomy, we do say NNT, number needed to treat. So if somebody has a sore throat, taking penicillin or any antibiotic, then NNT is 1. So,
yes.
So for IV thrombolysis, NNT was 7. For mechanical, NNT is almost coming down to 3.
Oh,
so,
wow.
So very powerful treatments. So I have seen patients who have been transformed after IV thrombolysis, mechanical thrombectomy, who we thought are not going to walk out of hospital. They have walked out of hospital in the first week of the treatment itself. And so it's truly sort of satisfying and encouraging to sort of get into these sort of areas of technology. Yes, stroke treatment is very cost intensive, but it is very, very, very effective. In bringing back good quality of life. And again, if somebody has a stroke, they become extremely disabled and they cannot bring money to the family. There's a huge care burden. The family has to support the person and so on. So I'm quite happy the stroke treatment is rapidly changing, but it's going to change even more.
I'm sure. Funnily enough, yes, I'm a cardiologist, and maybe because I'm a cardiologist, I'm not as scared of heart attacks as I am scared of strokes, because I truly do not want, I don't mind heart attacks coming and going. I feel like there's a little room to breathe or something like that, but strokes are a whole different matter. So it's very reassuring to hear that it is not a doomsday, that if you have a stroke, you're all done. You can actually salvage the patient and things like that. So let's talk about, post-stroke rehab, or what are our options there?
Immediately after any given stroke, we divide the time frame into hyperacute phase, acute phase, and subacute phase. So in the hyperacute phase, which is in the first 3 days after stroke, we try our best to restore the flow, and it comes along with its own complications. When there is a reperfusion, we see reperfusion bleed, there is increased cerebral edema, and these can be managed only if you have a properly set up hyperacute stroke unit.
So when you talk about cerebral edema, the brain itself swells up because of the trauma or the insult to it. Okay.
And because the skull is a tight box which cannot expand.
Yes.
So unlike in a chest cavity, the heart can swell up and down. But when the brain swells up, it can press the midbrain and cause sudden cardiac complications. So we have to carefully monitor and use anti-swelling medications. And there can be incidents of seizures after stroke, like epilepsy.
Okay.
And that is a very critical period. Once we cross that part, when we go to the subacute phase and the rehabilitation phase, it becomes more comprehensive and individualized.
Okay.
So stroke is truly a multidisciplinary disease. So right from the ER, then the radiology, intensivist, the stroke physicians, neurologists, neurosurgeons, specialist nurses who are well trained in the stroke unit. We need the help of physiotherapists, occupational therapists, psychologists, continence specialists.
Oh, wow. Okay.
A lot of people have to come together to treat one person. So
the brain is the brain. Okay.
So when we enter the rehab phase, so there are many types of rehabilitation. We have a conventional rehab where a physiotherapist will use a hands-on technique to make sure they get you out of bed so that you regain your sitting balance. Once you regain some of your sitting balance, then you could be made to stand and get some standing support and strength, core strength. Then only you can start getting up on your feet. In this road, again, rehabilitation is, as a specialty, has massively improved, especially neurorehabilitation. There's a lot of technology that has come into use, like assistive devices, wearable devices which can monitor the amount of exercise one is doing at home or in hospital. We can even advise patients while they're at home what all the exercise they have to do. We can get a video shot of patients who could be asked to stand, walk a few steps towards the camera. That can be captured, and the specialist can look at the pictures and say, he's got a weakness of the upper half of the arm, shoulder flexion, extension, finger flexion, extension, or your hip flexion, extension. So the treatment can be tailored according to individual patient. So we also can get speech and language therapists back home and initiate speech therapy and so on. There are a lot of other techniques like transcranial magnetic stimulation, direct current stimulation, which can improve the brain cells, help to rewire. Then in the end, we have robotic devices, wearable devices, which can be used to augment a person's walking style, walking pattern and balance. And the same devices can be used to improve hand grip so that they can use the hands and limbs more productively.
Okay, wow. I mean, this field with AI interference and everything, I feel like it's going to take a big leap and a big, it's just going to grow amazingly. I'm sure someone's going to come up with a specialized stimulator in the brain or something, which
so like Neuralink.
like a Neuralink kind of a situation.
Elon Musk.
Yeah, Elon Musk is going to jump on it, I'm sure, if he already hasn't jumped on it. Let's talk about a little bit of myths versus truths about stroke. Stroke only happens to the elderly.
No, stroke can happen to anybody. The youngest I've seen is an 18-year-old girl. So there are certain risk factors which are transient in nature, like post-infection, stress, like infective endocarditis, or even after viral infections. Patients who get chickenpox can develop arthritis, and that can lead to strokes.
Interesting.
Stress, I've seen individuals having a huge breakdown in relationships and so on, having Takatsubus, cardiomyopathy, coming with strokes.
Yes.
So it can happen at any age. But as we grow older, the risk factors are higher, so we may experience more strokes.
Okay, so it is not age dependent. Okay, that's number one. Let's go to number two. Number two, stroke, like how heart disease can run in families. Do strokes run in families?
Not really, but there are certain conditions that are hereditary. There is a very slight increase in stroke risk if somebody else in the family has had a stroke. That's simply because of lifestyle.
Yes.
The risk of other associated conditions that come with lifestyle, like diabetes, can have sort of cluster in the families because of the way they eat and exercise and so on. There are certain hereditary conditions or genetic conditions that can cause strokes, like CADASIL, like autosomal dominant conditions that are associated with premature small vessel changes in the brain. Also mitochondrial disorders that can cause certain strokes.
So those are all zebras.
Very rare.
Now, all strokes are caused by high blood pressure. True or false?
I would like to say true, because that is the least treated risk factor. But not all strokes.
So maybe most strokes are caused by high blood pressure.
I just want to emphasize the importance of hypertension that can be easily corrected. Because if we can treat hypertension promptly, nearly 60% strokes could be prevented.
Oh, wow. Okay. But the problem with hypertension, high blood pressure, which is what we call as hypertension, we don't know. I mean, it's called a silent killer for exactly that reason. It can cause brain strokes in the brain, heart attacks, and kidney disease, everything. It's such a common disease, so untreated. So
like 1/3 of hypertensives may not know they have hypertension, even if they know.
They're not adequately controlled. Okay, now next, myth number 4, or true or false, number 4. A stroke always causes paralysis.
Not really. we get to know them if they come to us with a paralysis. But if a stroke happens in the back of the brain, like in the occipital cortex, where visual information is processed, they can go unnoticed. We do see patients MRI showing a large stroke in the back of the brain, and they have not picked it up at all. Often we do see silent strokes due to especially poorly controlled hypertension and diabetes, which gradually accumulate, and they present to us with what we call as vascular Parkinsonism.
Yes, or vascular dementia.
Vascular dementia. So they may have gait imbalance, bladder bowel control issues, and memory difficulties. And so we do see a surprising number of white matter changes due to silent strokes.
There is this thing called mini strokes, which, they call it TIA, they call it mini strokes. Mini strokes are harmless. What do you think?
Something that we should really catch on. Mini strokes are almost like angina before a heart attack comes. They are warning strokes, and that's the best opportunity to catch individuals who could have a very large stroke in the next week or two. If you look at large strokes, nearly 20% of them would have had a TIA or mini stroke in the 2 weeks prior to that, the incident stroke.
So let's, take a break from this rapid fire and go to mini strokes. So what do you mean or define by mini strokes?
So mini strokes, still the definition hasn't changed. If somebody has had a neurological event and they have recovered within 24 hours completely, it's called a mini stroke. But in reality, most of the mini strokes recover within the first 10-20 minutes itself.
Oh, wow.
And with a lot of advancements in technology, like when the mini stroke definition happened, it was in those days when they had CT scanners. So CT scanners often will not pick up small changes in the brain. With MRIs, we can pick up the smallest change in the brain. And even in certain mini strokes, 20% of MRIs can be negative. So we now have classified it as DWA positive, meaning the DWA is the MRI change in mini strokes, or DWA negative mini strokes. If you think clinically it is a mini stroke, it is a mini stroke.
Oh, so it's more of a clinical. So you mean to say I'm going to have an imbalance, but in 20 minutes the imbalance goes away, or my speech is slurry for 20-30 minutes and then it goes away. That is going to be a very tricky situation.
So often it gets ignored.
I can truly see that. So let's get back to our rapid fire. Aspirin can prevent all strokes.
So aspirin is a very good drug, but NNT for aspirin is almost 150.
Yeah, there's numbers need to treat to prevent one stroke is about 100.
More than 150. So again, we often use dual antiplatelets, meaning aspirin plus another agent like clopidogrel. But surprisingly, in India, especially in Chennai, what I've noticed is the resistance to clopidogrel is enormous.
Yeah.
So when they come in with repeated strokes while they're on two agents, when we check it out, we are surprised to know that there is a lot of prevalence of clopidogrel resistance in our country.
So, clopidogrel is a medication I am very familiar with because we use it to prevent the stents from clotting off. And so almost all patients who have heart attacks or stents get clopidogrel. And it's really scary that clopidogrel resistance is pretty high here. Okay, now let's talk about stroke recovery. I mean, myth, true or false? Stroke recovery is possible only in the first 6 months, and after the 6 months, they don't recover.
That was what we were told when we were medical school, like in the first 6 months, do all you can, and if you haven't made anything beyond that, no point wasting money and so on. But what we really see now is the recovery extends beyond a year, and we have seen patients who have come back after 5 years of stroke, and with the right set of exercises and treatments, we have seen a little bit of changes that can add up to much better quality of life. So the recovery never stops.
Yeah.
The brain can still adapt.
Yes. So that's the term neuroplasticity, right? Where the brain still learns to do new things, even though it has suffered a big insult like a stroke. That's fantastic. I mean, that's the human body. The human body is extremely resilient overall. Now, strokes are always painful.
Not always. Maybe when we have a hemorrhagic stroke, like a bleeding stroke, we may have some headaches. In certain strokes, like cortical venous sinus thrombus, where the outflow of blood through the venous sinus, when they get clogged, we may have headaches, and that can cause a venous stroke. So when the blood is getting into the a brain that cannot get out, it starts leaking in the brain parenchyma.
Okay, okay.
In those scenarios, we may have a headache,
Okay.
but most of the time, we don't see pain in ischemic strokes,
Yes,
especially.
okay. Like once you've had a stroke, and let's say you're on the right treatment for strokes, what is the second stroke risk?
So the year-on-year stroke risk is roughly about 20%. So if
Oh.
somebody has a stroke, there's a 20% chance of them having another stroke. But with the right risk factor control, we can bring it down below 5%.
Ah, okay, fine. That's reassuring. When you started with 20%, I was like, this is a staggering numeric. Okay. But when you talked about rehab, how aggressive are the rehabs? I mean, can you just do 20 minutes of rehab? Do you need to be on rehab the whole day? How does it go about?
So in the first 3 to 6 months, it should be extremely intensive. And if you look at countries that do extremely intensive rehab, like the Scandinavian countries, Germany, the Western Europe, they spend nearly half a day in rehab. But if you go to UK, Australia, where it is more government-run setup, maybe 1 hour, 1.5 hour
Okay.
rehab is the max that
Maximum.
can happen. But if you go to proper rehab setups, they live in rehab. They pretty much have it almost for 6 to 8 hours. And those are the time frames that help for maximal recovery. That includes a few hours of physiotherapy, few hours of occupational therapy, speaking to the psychologist, meeting with family, also to do with speech therapy, swallow therapy, language therapy. Speech and language are two different things. So then you have to give cognitive therapy and get them on to be more executive in what they can do.
Yes.
Like in the previous before strokes.
Sure. Stroke is clearly, still a very evolving kind of a area. I mean, you said the first randomized control trial came in 1995, which seems much more of a delay compared to cardiac disease and stuff like that. What are the future prospects in stroke care?
So there's a lot of research interest in stroke care, especially in the neuroprotective arena. So yes, we can get the clot dissolved. We can mechanically retrieve the clot. But what happens to the tissue that is
Yes.
getting damaged?
Yes.
So there's been a lot of medicines that's been trialed, what we call as neuroprotectants, but none of them have been successful as of now. Nearly 10,000 drugs have been trialed, and more than thousands of trials have been come and gone. But there are a lot of new promising medicines that have come through, which can arrest the cellular NG process. It can arrest the oxidative stress in the cells, almost like hibernate them until the mechanical thrombectomy has happened. So these drugs can be used before they are brought to hospital in the ambulance. Some of them can be used in the hyperacute phase, some can be used in the post-acute phase. And there's a lot of advancements in managing spasticity also.
So define spasticity.
Spasticity is what happens after limb has become permanently immobile. So the muscles that are more active or more powerful become more
Kind of
tighter,
contracted.
more tighter, contracted. So often when you see stroke patients, they have a
One-
like adducted shoulder, a flexed elbow, and a flexed wrist, and they walk with a circumduction gait. They sort of swirl the leg around when they walk. That's because certain group of muscles are overactive and they get fixed in that way.
Yes.
So we can reduce the spasticity with drugs like Botox and other drugs like that group called hyaluronase, regenerate the muscles and so on. So there's a lot of promise.
Botox can be actually being used for beyond skincare. That's interesting. That is, what else is happening in the world of stroke?
I mean, robotics. That's one of the key advancements. Robotics are transforming the acute rehab phase and also helping individuals who have gone past the long-term rehab phase. So they can maximize quality of life with minimal effort.
Okay.
So if somebody is struggling to walk up and down stairs, with simple wearable robotics, they can easily go up and down. They can drive a car, take their kids to school and come back, go for a walk. And a lot of things can be done with these wearable technologies.
Fantastic. So the future is definitely looking brighter, even if you've had a stroke. That's what I'm getting at.
But the key is to identify it early, come to the right place. So as we were discussing earlier, quite often individuals are taken to centers that are not equipped to treat strokes. So in the States, you cannot do that.
Yes, you'll be fired. You will lose your hospital will shut down.
I think we need to have a legislation
Yes.
to make sure if somebody goes to a setup where they cannot treat patients, they should direct them to a stroke-ready hospital. And again, we should roll out certification programs for primary stroke care centers, secondary stroke care centers, or comprehensive stroke care centers, where the general public will know which places are actually meant to be
That's interesting.
treating them.
That's a great message. You know, before we started recording, you were talking about some registries and databases which are available in other countries. Can you talk about that and why that's important?
So when I was getting trained in UK, I would every day spend at least 20 minutes entering my patient's data in the UK stroke registry.
Okay.
And the system has got a fantastic data collection online tool. And every year they roll out prizes for the best hospital that has done the shortest door-to-needle time.
Okay.
Who have achieved the targets like seeing a speech therapist within a certain time frame, seeing an occupational therapist within a certain time frame, who has got the highest number of discharges in a certain time frame, which hospital's got the highest number of outcomes in terms of back to work, continence, psychology, and so on. They capture everything. So we can start with simple data first. So like at least number of strokes that are happening, whether they are ischemic, hemorrhagic, and then we can slowly expand. So same thing happens in the whole of Europe. They have a centralized system where they just collect the data. In India, we do that for tuberculosis, for example.
Okay.
So if anybody has been diagnosed with TB, there is a centralized system where we have to notify the government. So we have done extremely well in eradicating malaria, leprosy, and we are doing extremely well with TB. So same thing can be rolled out for non-communicable diseases like MIs and strokes.
I hope you're able to achieve that, Sivarajan. That sounds like a very lofty and a very commendable goal for you to pursue. I mean, we are kind of coming close to our end of our podcast. Do you have any final words you want to tell a patient, who's concerned about their overall brain health and stroke health? What can they do to prevent a stroke and keep a stroke at bay?
Okay. They should watch your podcast.
Thank you very much. I will take that.
There's a lot of information on lifestyle, controlling calories, and the right type of exercise, right type of food to take, and so on. That's enormous amount of information that is really life-changing.
Thank you so much. I appreciate that. I think we should end it right here. No, please go ahead.
Prevention is the key.
Yes.
So if we can keep the numbers in order, like blood pressure less than 130/80, HbA1c less than 7, LDL-C less than 70 at least. In MIs, you want it to be less than 55, I think.
Yes.
And at least 150 minutes of moderate exercise per week.
Eat healthy.
Especially people in a lot of our workforce is in IT. They sit all day.
Yes, very sedentary lifestyle. Yes.
Sitting is the new smoking.
Yes.
So they have to get up and do something during their working hours. And when somebody has a stroke, don't waste time and come to a proper stroke-ready hospital where things can be done instantly.
Yes. And quit smoking. Don't start smoking. And if you are smoking, quit smoking. Let's never forget that. With that, thank you. Thank you so much, Sivarajan. It was really a fun conversation and a very important conversation. And you truly are talking about, creating this registry, certifying hospitals so that patients know where to go and so that they get the right care. Thank you so much for joining me.
Thanks for having me. It's a pleasure to talk to you.
Thank you, guys. I hope you enjoyed this podcast, and I'll see you on the next round.